disorders. There may be rashes, arthritis, pain, with some constitutional symptoms like fever, fatigue, weakness, weight loss. In the skin, classically we get this malar butterfly, hence the word lupus has been derived, along with alopecia, photosensitivity, purpuric spots. Raynaud's phenomenon is particularly common in the elderly age group in women with urticaria, vasculitis. In the GIT, there may be features of nausea, vomiting, and other GI irritations. In the kidney, patient will suffer from proteinuria and later may progress to hematuria, and proteinuria may be in the nephrotic range. Hematologically, there will be anemia less than 10 from thrombocytopenia of less than 1 lakh platelets and leukopenia of absolute neutrophil count less than 10,000. There will be pericarditis, endocarditis, myocarditis, and other features of serositis. It's generalized serositis basically. Neurologically, patients will have seizures, psychosis, peripheral neuropathies, and also cranial nerve abnormalities. In the respiratory system, there will be pulmonary hypertension, good IC, and parenchymal diseases. So just to picturize this classical butterfly rashes will be seen with other symptoms. Pleural effusion or any other third phase correction is also a part of it, and kidneys will apparently show features of CKD, arthritis, and renal phenomena in the extremities, especially in the elderly women. So basically it runs around 5 pathologies. First of all, the threshold of immunotolerance in the body will be reduced. Secondly, the regulations of both CD4 plus and CD8 will be altered. Then also we have certain genes that interact with the environmental factor, and as a result it triggers an autoimmune reaction. And finally, there are features where there is decreased clearance of the antigen-antibody immune complexes to the kidney. So drugs may be remembered as please check home in SIP for academic interest, of course. These are the commonly found drugs: procainamide, lithium, etanercept, AC inhibitors, statins, especially the antihypertensives which are commonly used, then barbiturates, OCP pills, methyl dopa, then chlorpheniramine and CPZ4, sulfonamides, hydrazine, INH, and phenytoin. These are the commonly used drugs that are known to cause SLE. Now this is the spectrum of the disease. As we can see at the center, only 19% patients will have such advanced level of disease that most of the multi-organ system involvement may be seen. So articular manifestation takes around 24%. Cutaneous, which is quite common, takes around 34%. Renal involvement is 19%, and the remaining of the graph shows the overlap of all the manifestations. This is the worldwide incidence of SLE. As we can see, more common in the Western countries, especially in the United States and Canada region, accounts for around 18 to 27%. This is mainly because of two factors. They have their lifestyle and other things makes them less encountable towards the antigens. So antigen antibody hypersensitive reactions are more common, and also statistically their lifespan is more than their counterparts in the developing countries. So chance of autoimmune feature is also more. Asia accounts the highest, around 44%, and India is also part of it. It's quite high also in the South American nations, around 39% in the upper value. So this is the criteria for diagnosis. 4 of the above 11 criteria, if it is present in the patient, then we can label it as a case of SLE. What we get is a discoid rash and also malar rashes at times, photosensitivity with oral ulcers which are usually painless, arthritis, and important to notice it is a non-erosive type of arthritis in these cases. Serositis will have its features in the lung, in the heart, and other places. Renal disorders, it may progress up to stage 5 as we saw in this case. Neurological disorders, as we have seen, psychosis, seizures, and other involvements. Hematologically, there will be anemia, thrombocytopenia, and also decreased in the absolute WBC count. Immunological disorder that is the central pathogenesis, we will come to details of it. An anti-nuclear antibody test, panel of test, and malar rash we have already explained. So to classify this lupus nephritis, it is basically a classification after the biopsy has been taken. So class 1, as the name suggests, minimal essential lupus nephritis. That means under the microscope, light microscope, it is usually a normal kidney tissue. Only under immunofluorescence or electron microscopy, immune deposits may be seen. In class 2, which is known as mesangial proliferative lupus nephritis, there will be mesangial hypercellularity along with immune deposits. Now, class 3, it is focal lupus nephritis. The word focal suggests there is involvement of less than 50% within the glomerulus. And this, based on the activity of the disease, is classified into 3 types. One is active, one is active with chronic, and one is only chronic. Class 4 is diffuse lupus nephritis. That means more than 50% of the glomeruli has been involved. So again, this is broadly classified into 2 types. S is added when there is segmental involvement, and G is added when there is global involvement. And if we combine this along with active chronic and active on chronic, we get these 6 types of sub-classifications of class 4. So in active and chronic, what happens? Along with segmental proliferation, there is also sclerosis. And this class 4 is the commonest, and unfortunately the most, it has the worst prognosis among all the types. Class 5 is membranous lupus nephritis, that is global or segmental subepithelial immune deposits. And class 6 has advanced sclerotic lupus nephritis, with more than 90% of the glomeruli is involved, and often there is no residual renal function. So histopathologically, we have seen the hyaline thrombus deposits along with involvement of the glomeruli. Now in this glomeruli, based on the extent of involvement, we can classify that more than 50% will go to class 4, less than 50% will go to class 3. In retinopathy, there will be exchanges, basically a pale type of background in the retina, and essentially induced retinopathy along with photophobia and other ocular features. In arthropathy, as we have seen, it's basically a non-erosive type of arthropathy, and basically, if eosin is absent and joint involvement more than 5, then we can label it as a multi-joint involvement. Less than 5 is quasi arthropathy. Now some of the studies have been made on, because it's an issue that the steroid has to be given. So how much steroid and for how long? So various studies have been made in this, and based on that we have reached to a consensus which will come to the treatment part later. Basically what we have is an induction phase, a maintenance phase, and adjuvant therapies. So microphenotypal, which is largely steroid sparing agent, is given at rate of 3 grams IV or per orally daily for a span of 6 months. Cyclophosphamide is also given at 500 mg IV every 2 weeks, maximum of 6 doses. And if response is not adequate, it can be raised up to 1 gram per meter square of the body. Methylprednisolone started on pulse dose, also up to 1 gram IV daily into 3 doses, followed by gradual tapering down of 1 mg per kg. Now this 1 mg per kg per day itself is a very high dose, and even that has to be tapered gradually. In the maintenance phase, we have microphenotypal of 1 to 2 grams per oral daily, and the treatment is quite long for a span of 3 years. Along with other immunosuppressants like azathioprine, the dose is 2 mg per kg per day for a span of 3 years. Hydroxychloroquine, which is also a potent immunomodulator, can be given daily if adequate response is observed for 200 to 400 mg per day. Now various studies have been made on the other immunosuppressants. Rituximab biologics has come up. So the basic dose of all these studies is almost the same, that is 375 mg per meter square. So 4 subdivided doses are given. Responses vary from place to place. In this, the Pinto trial made on 2011, that is the second latest one of all, has shown maximum maximum success rate with a higher dose of 1 gram given for a shorter interval with almost 65% curance. Other studies using lesser doses of 375 mg per meter square, the success rate ranges from 26 to 29. So what are the indications to start steroid therapy? First, there is an acute lupus crisis. Then secondly, there is active FID disease as seen either by clinical biological or and mainly by the biopsy findings. Then acute active CNS features, then acute cytopenias, refractory serositis, vasculitis, and other severe constitutional symptoms. Now, what is the incidence of SLE in diabetic patients? So, worldwide the incidence is 0.07 plus minus 0.009. That was a study on 2004 and 5. Whereas incidence of diabetes in SLE is very high, that is more than 0.90%. This is mainly due to the need of prolonged use of steroids. So this is the outcome of combination therapies by rituximab, cyclophosphamide, and also steroids. And 6 patients were followed up. This is the study in the British high-grade lupus assessment group, and the outcome is almost total in all the patients. So basically, what they try to prove in this study is combination of these 3 drugs gives a optimal result. Now, what we should keep in mind is any young lady or who presents with constitutional symptoms with like fever